My name is Michael Kinnucan. I'm the Health Policy Director here at FPI, and this is the technical briefing on healthcare for real Medicaid sickos who want to know the gory details of how things work in the healthcare budget. I'm going to preface this by saying the healthcare budget is large and opaque, and it happens not only in policy but also in the fiscal issues in the enacted budget financial plan, which is not actually due out until about a month from now. And so what I'm going to cover today will not include sort of the overall picture of spending on Medicaid because that is not decipherable from the enacted budget, oddly enough. But we'll cover trends, coverage issues, policy choices, and then at the end, I'm going to zoom out a little bit and sort of reflect on where we are in the history of New York State healthcare access and sort of what new ideas we can take away and move forward from here. So, and I'm going to talk for about 40 minutes. I'll try to be quicker, but it may well take that long. And then I'm going to open it up for Q&A. Please do use the Q&A feature in the webinar throughout the presentation because that'll make it easy to keep track of questions as they come up. And broadly speaking, what I'm going to work through here is, the context in which this budget was debated and ultimately passed, the result on healthcare coverage, some actions to increase hospital and nursing home rates, and then, policy, not strictly financial actions in the budget, and then that broader reflection on sort of where we're going. So the context for this budget had, mostly very negative character, right? Because we saw a really massive cut to healthcare passed over last summer by Republicans in Congress and signed by President Trump. The One Big Beautiful Bill Act was a lot of things, but primarily it was a giant tax cut funded by a giant Medicaid cut, and that cut is now impacting New York. So we were seeing a federal funding squeeze there. The good news for New York is that we were in a relatively good place to respond to this cut because we had not only growing state revenues, but actually slowing Medicaid spending. You won't hear this on the evening news. You won't hear it from the governor. Policymakers tend to like to describe New York State Medicaid as a sort of rapidly expanding cancer that can't be stopped. But as a matter of fact, Medicaid in New York, the spending was moderate and slowing. And so we were in a place to potentially respond to cuts without just passing them through to patients and providers. And then the other piece of healthcare context here is, state budget politics tends to focus on the aspect of healthcare that is on the state budget, i.e. Medicaid, the essential plan, safety net hospital funding. But the larger picture of healthcare is really important. The aspect of it that is on private budgets of employers and workers who pay for private insurance, the individual market, and so forth. And that context has just gotten worse in New York State in the past several years. Healthcare costs continue to rise really rapidly, unfortunately, pushing a growing crisis of healthcare access. So those were the contexts. Just to put some numbers on that, mainstream Medicaid enrollment had returned by the beginning of this calendar year back to pre-pandemic norms. So mainstream Medicaid enrollment is like the core of the program, health insurance for low-income people, not including long-term care, not including the Medicare Savings Program and all the other stuff in Medicaid. That was around 4.5 million before the pandemic in 2018, 2019, and then it spiked really dramatically over the course of the pandemic, both because people lost their jobs and because the federal government issued regulations requiring states to keep people on Medicaid, even if they maybe no longer qualified or didn't renew. So there was this huge spike, and then pretty rapidly there was a return to the norm. And so we're back at sort of regular Medicaid enrollment. The other really important trend that was even more impactful budget-wise was a really dramatic slowdown in managed long-term care spending and even a reversal. So the Medicaid budget is most of the Medicaid enrollment is in health insurance, but most of a huge proportion of the budget, almost half, goes to various kinds of long-term care. And in recent years, long-term care growth, home care growth, was sort of driving the overall Medicaid budget picture. The CDPAP transition, which was extremely messy and traumatic for workers and beneficiaries, it for various reasons really caused MLTC growth to slow, and you can really see this clearly in this graph. This was in our executive budget presentation, that the CDPAP transition and then a change to home care eligibility last September really changed the growth trajectory there. So Medicaid spending was growing at a moderate 5% as proposed in the executive. And that 5% was largely driven by provider rate increases, not sort of underlying program trends. But of course, the federal context for this budget was really bleak. And I've talked a lot about this. I'm just going to hit the highlights. There are Medicaid work requirements coming into effect in January 2027. We project that those could cause 800,000 people to be kicked off New York State's Medicaid program over the 2 years or so after January 1st, 2027. The reason for that is not that so many Medicaid beneficiaries aren't working or qualifying for an exemption, but that any time you introduce bureaucratic processes to sort of disrupt people's maintenance of coverage, it means people slip through the cracks, and we expect that to happen. And another feature was a dramatic cut to New York's Essential Plan, which covers 1.7 million New Yorkers. I'm going to talk a lot about that today. And then there were also cuts to ways that the state funds high Medicaid providers, including the MCO tax was ended by federal cuts, and there is a coming phase down of state-directed payments, which are a major source of safety net funding for hospitals. And then again, just to emphasize, the cost of a family health insurance plan has almost tripled over the past 20 years. The cost of an individual plan has more than doubled. So the sort of private health insurance costs remain a huge issue. So I'm going to start by talking about health insurance coverage issues, meaning primarily Medicaid and the Essential Plan. And I'm going to just start by saying the picture is really bleak. This state budget did very little, indeed nothing, I would say, to prevent the huge loss of Essential Plan and Medicaid coverage we're facing over the next month and over the next 2 years. This graph is from our executive budget briefing. We said, look, if the state doesn't step in and act, then we're going to see over 1 million New Yorkers lose health insurance. It's going to be the most rapid loss of health insurance in New York State's history. And all of the insurance coverage progress that we've made as a state since the passage of the ACA will be essentially reversed. So we're going to go back from being a state with over 95% health insurance coverage to a state with, 10% of its population uninsured. And that is indeed the trajectory that the enacted budget puts us on. It's really, really concerning. So just to sort of run through it, the biggest component of that health insurance loss is going to be Medicaid work requirements and also Medicaid beneficiaries in the ACA expansion population will now be required to prove that they're eligible every 6 months and prove in that context that they're working. Again, we expect a huge number of people to fall through the cracks, although state DOH is working hard to prevent that. The picture we found out last week is actually even worse than had been projected because the federal regulations implementing work requirements have finally been published. And unfortunately, they're even more distressing than was predicted. And so our expectation is large insurance loss from this. We advocated for state funding to catch some of these folks who roll off Medicaid due to work requirements, but the enacted budget did not do anything about that. And so that's the course we're on. I want to talk a bit more in depth about the essential plan and the sort of background of it. We're also expecting a huge coverage loss due to cuts in the essential plan. The headline here is basically that the enacted budget cuts eligibility for the essential plan from 250% to 200% of the federal poverty line, which will cause 450,000 people to lose coverage. But I want to talk a little bit about what the essential plan is, how it works, and why we ended up here. So, the essential plan covers 1.7 million people right now. It's about to be many fewer who are under the 250% of the federal poverty line, but are not eligible for Medicaid either because of their immigration status or just because they have high income that's too high for Medicaid. And 250% of federal poverty is about $40,000 a year for a single individual. So it's not a lot of money. These are working class and low income people. And the essential plan, the key thing to understand about it is that it is a very efficient, very solid way to provide coverage. So, the essential plan costs well under $7,000 per individual enrolled to provide really high quality, zero deductible health insurance coverage. That's in contrast to private employer insurance, which costs, $11,000, $12,000 a year, depending on where you are in the state, and comes with a $2,000, $3,000, $4,000 deductible. So this is really a great policy. And why is Essential Plan so cheap? Well, number one, it regulates provider rates. So the state says that Essential Plan insurers will only pay 225% of the federal of Medicaid rates, which that's, more than twice what Medicaid pays, but it's still less than what commercial insurance pays. The other source of essential plan efficiency is that because it is free or very, very cheap, many people enroll in it who are low income and might not be insured if it costs them a lot of money to be insured. And the result of that is you get a very healthy risk pool, which holds costs down. So before the essential plan was cut this year, before HR 1, the essential plan was funded by basically federal premium tax credits. So in other states, federal premium tax credits primarily go to help people buy private insurance on the exchange. In New York, we were using premium tax credits to fund the essential plan. And because the essential plan was so much more efficient than private insurance, it actually produced a significant surplus. So we were using these premium tax credits that only partially subsidized private coverage, but we were using them to subsidize much more efficient public coverage. And the result of that was that we actually were fully funding the plan via via these premium tax credits. It didn't cost the state anything. And and we even actually were accumulating in the first 10 years of the Essential Plan a surplus, which is still there. The Essential Plan Trust Fund surplus is now at $10 billion. And I emphasize this because I think that within New York healthcare policy circles, there's a sort of misapprehension that the Essential Plan was kind of like a magical thing that was funded by some strange aspect of the federal reimbursement formula, and we were getting a free lunch out of the federal government by running this program, and then the free lunch went away, so of course we have to cut it. What I want to emphasize here is no, we were running a great program that insured low-income New Yorkers at a very, very low cost. And so the federal government was only giving us what it gives every state, i.e. premium tax credits that subsidize insurance for low-income exchange enrollees, but we were doing a smarter thing with it that allowed us to cover more people and provide higher quality coverage. And so in the first 8 years of the Essential Plan, it was this crazy thing where it was working so well that we were operating at a surplus, we were accumulating money. And finally, in 2023, the state decided to find a way to sort of beef up the Essential Plan to spend that ongoing surplus. And so we did really two things in this period. Number one, we increased provider rates within the Essential Plan. Originally, the Essential Plan was only paying 1.25 times Medicaid. We almost doubled that to 2.25 times Medicaid. So that was good for providers. It didn't really change the dynamic for enrollees, right? You're not that worried about what your hospital gets paid to provide care for you. But it did help safety net providers. It was a good way to spend the money since we had the money. And then much more visibly and saliently, we increased the eligibility threshold from 200 to 250% of the federal poverty line. And that caused a huge expansion in enrollment. About 450,000 New Yorkers enrolled in the Essential Plan. And this involved shifting regulatory authority from the basic health program to Section 1332 waivers. And so we had changed the program to spend the ongoing surplus, but we still had the accumulated surplus of 10 billion. So the HR 1 led to really massive cuts to the Essential Plan, basically through the mechanism of it cut off premium tax credits for lawfully present immigrants, just as a sort of attack, not on undocumented, but on lawfully present immigrants, green card holders, and so forth. And the result of eliminating that in other states was that, now those immigrants won't be able to purchase coverage on the exchange. And so they'll become uninsured. Here in New York, it took the form partly of that for higher income immigrants, but largely of a massive loss of Essential Plan funding, about half the funding. So we were getting about $13 billion to run the program. We lost about $7.5 billion. And so, given these cuts and given that this was such a great program, there were a few different options we would potentially have had to keep it sustainable. We could have put in state money to cover some of the gap. We could have found a way to access the Basic Health Program Trust Fund that accumulated $10 billion. We could also have reduced provider rates back to their original level back in the origin of the program, right? I said we had doubled provider rates because we had extra money. Now we don't have extra money. Why not reduce provider rates a bit to stretch the money farther? And then finally, we could cut coverage. And basically, what the executive proposed and what the enacted budget does is to, number one, cut coverage, number two, access the trust fund. And so the result of that is we're reducing Essential Plan eligibility back to where it was before the expansion. Those 450,000 people who got coverage in 2024 will now lose coverage beginning July 1st, 2027, 2026. I'm sorry. This slide is incorrect. 2020 they will lose coverage on July 1st, this coming July 1st in 3 weeks. So I apologize about that. And so we're going to see a massive, 3 weeks from now, a massive, very sudden loss of health insurance coverage. But we aren't stretching the money in any other way. We're not cutting provider rates to make more fiscal room. We're not, and so the result of that is even this new reduced essential plan will be partly subsidized by actually spending down that $10 billion trust fund, which raises questions of long-term sustainability. In 3 to 4 years, that money may be used up and we may have to revisit. And so there's an important question in the budget was what will happen to these folks who lose the essential plan? You could imagine that they could find some way onto employer coverage, that they could buy coverage in the individual market, or you could imagine that they will become uninsured. The executive projected that a huge number of people will find employer coverage. I see no reason to believe this, and I've written a blog post about it that you can review, but I think, and advocates believe, that the vast majority of these folks will become uninsured. I want to talk a little bit about sort of the policy context here. My understanding is that in the in the inner circles of high-level policymakers, one of the reasons why we decided to do this massive loss cut in New York health insurance is that some influential people felt that, when we expanded the essential plan in 2024 up to 250% of poverty, we crowded out employer-sponsored insurance, meaning a lot of people and a lot of employers who were previously getting and providing employer insurance sort of saw that the state was offering something better, and dropped that coverage or changed jobs to jobs that didn't offer that coverage and so forth. And that is, I think, and so the hope was, well, if we cut back, then employers will step up and provide coverage. I again think that that is really not reasonable. I think there's a failure of policymakers to appreciate just how much more expensive health insurance has become over the last several years. There's just no way that we can expect, small businesses that are paying low wages, $40,000 or $35,000 a year, to step up and buy a health plan that costs $11,000 a year. And so to the extent that employers did drop coverage in response to the essential plan, it's very unlikely that they're going to come back and restore it now. And there's another question of, more basically, why would we want that? The essential plan is much better and much cheaper to provide than employer-sponsored insurance. And so there's a real, I'm going to talk about this more later, but there's a real sort of confusion among policymakers about the extent to which we can rely on employer-sponsored insurance as a backstop. I'll just emphasize that whether people find alternative insurance or not, we're really going to see a massive loss of health insurance access because people who lose essential plan coverage, even if they find alternative coverage, they'll see premiums of $250 a month, and they'll see deductibles in the $3,000, $4,000, $5,000 a year range. And so, just because you have health insurance doesn't mean you can use health care, and we're likely to see a lot of folks lose access to their health care on July 1st, this coming July 1st. So this is a real austerity budget in terms of healthcare access. We're seeing a huge, huge loss of health insurance. But it's not an austerity budget on Medicaid and healthcare spending broadly, because we saw a really, really large increase in provider rates. And so, the context here is that over the past several years, the state has increased provider rates for hospitals and nursing homes in particular. Um, Despite these rate increases, the state still needs to sort of supplement healthcare, its payments to hospitals by supporting safety net hospitals to the tune of maybe $7 billion a year, like a really significant amount of money. And under the Republican reconciliation bill, we're seeing a lot of threats to safety net providers, including, that coverage loss will increase uncompensated care costs for those folks. MCO taxes, the MCO taxes going away, and DPT cuts are set to phase in, as I'll talk about. So the big acute issue that this budget had to deal with was loss of MCO tax funding. The MCO tax was basically a mechanism for increasing federal Medicaid revenue for New York. It was kind of a circular tax where we taxed Medicaid MCOs and then we spent the money back into Medicaid. And the net result was that no one in New York really paid more, but the federal government, because it was matching our Medicaid payments, did pay more. This was always viewed as a short-term solution because frankly, the federal government, even under Biden, wasn't happy that we were doing it and was saying it was going to regulate it out of existence. But it was expected to raise a net of, $3.7 billion over three or so years. And then HR1 passed and said, the federal government is going to issue regulations banning these taxes. And we originally thought they would end at the beginning of this calendar year, which would have meant we could only raise about $2 billion. And then ultimately, the regulations came out and said we could keep the tax until the end of this calendar year, so an extra year of the MCO tax. So we were going to raise 3.3 billion. But at the beginning of this budget cycle, we didn't know that. There was a significant loss. And the governor essentially backfilled that loss by putting $1.5 billion of state money into provider rates. I will say this was never a surprise. We were always getting MCO tax revenue on a short-term basis and then investing it in provider rates, which are not going to go anywhere or go down. So we were always going to have to, as a state, sort of take this spending onto the state budget. And now we have, basically. So the MCO tax is over. We're putting in state money to sort of backfill what it was funding. There is a new MCO tax, which I just want to sort of flag and talk about. This is sort of described in the press as like we modified the MCO tax to comply with the new federal guidelines. I would see this as a very different thing. So the old MCO tax was basically just a way to raise money from the federal government. The new MCO tax is actually just an across-the-board tax on all health insurance in New York. And so, it's a small tax. It's 0.35%, and it's expected to raise about $165 million a year. This will increase health insurance costs for everyone who pays for health insurance in New York. So that's employers, individuals, unions. I want to sort of keep that in the context of we're a state where health insurance premiums just go up by 6 or 7% a year. So you won't even notice the 0.35%. So it is not a huge deal and it's not a huge amount of money, but it is a shifting of the burden here. And then, the short sort of version here is the executive really backfilled federal cuts to the MCO tax and to provider rates by putting $1.5 billion all funds into hospital and nursing home rates. The executive budget did include some limited offsets to that spending. but they weren't large, and the big story was significant state funding for provider rate increases. And the enacted budget basically maintains those increases while reversing some of the offsets. And so the enacted budget is sort of in line with the executive budget and how generous it is to hospitals and nursing homes in particular, but a little bit more generous. And so what we saw is, hospitals are getting about $1 billion extra in the form of rate increases and a quality pool, which I'm going to talk about in a minute. Nursing homes are also seeing really significant rate increases. There's a smaller bit of money to increase FQHC rates. There's some money for mental hygiene providers, which I'll talk about. And then there's QuivApp, which is a somewhat obscure program that basically subsidizes unionized home care workers' health insurance. And so if you add that all up, you're looking at about $2 billion. This is, again, all funds in increases to provider rates. So I want to just sit for a minute with this contrast between massive cuts to coverage and really, really large increases to provider rates, because I think it reflects, this is not only sort of what was reflected in the executive budget, it was reflected also in the one house legislative budgets. And it's a real policy choice, right? I think, our political leaders in New York are trying to say, well, look, a lot of people are losing health insurance, but that's because of federal cuts and we can't backfill it. But in fact, we could backfill some of the cuts, and we chose to backfill the cuts to providers and not the cuts to health insurance. So I think that reflects people's priorities. I want to just linger for a minute on this $250 million hospital quality pool. I have not been able to find any information on what this quality pool does or is intended to do. For folks' context, a quality pool is basically it's Medicaid spending outside the rates that goes to providers that rewards them for quality measures. So you might say, oh, we're going to have a distribution formula that rewards providers that have a low level of rehospitalization for inpatient procedures or whatever. But, because you have a lot of discretion in how you write the formula, it can be kind of squishy to like send money to some providers, but not others. And it's a significant amount of money, obviously, even in Medicaid, $250 million is not nothing. And as far as I know, there's no public information about what this money is for or what it's expected to do. So email me if you know or have a guess. The other thing I'll say here is in the sort of mental hygiene funding world, this is, there are a bunch of mental hygiene offices, which are now being nicknamed the O agencies, OASIS, OMH, OPWDD, that have mostly services provided via subcontracts with nonprofits. The nonprofits are providing direct services to people with mental health issues. Direct care workers in this industry are often extremely, extremely low paid. And in the past several years, the state has done small, quote unquote, targeted temporary inflationary increases, basically, flat percentage increases to all the providers in these departments. The executive proposed a very small one of 1.7%. Advocates were hoping for a much larger one, about 4%. The enacted landed in the middle at 2.7%, which works out to be about $280 million, all funds. And, I think advocates were really, and labor unions were really hoping to see this funding, whatever the amount, go into worker wages, because that's sort of where the rubber hits the road for these services. And again, workers are often very low paid. But unfortunately, there was no language doing that, and so it's going to be up to the providers to decide how to allocate this money. I want to talk a little bit about safety net funding. So, this is funding for hospitals that, because they're high Medicaid, high uninsured, rural, in poor neighborhoods, what have you, um, treat a lot of Medicaid and Medicare patients. Those programs pay way less than commercial insurance. And as a result, hospitals that treat those patients are sort of perennially underfunded. And so outside of Medicaid rates, the state spends a significant amount of money just directed to those specific institutions to try to keep them open. And, this is a graph of all of the different acronym programs that do that. This is from the executive budget. It reflects a cut because the executive proposed cutting $500 million from VAPAP, which is the yellow bars there. That cut was restored. And so basically, safety nets are flat funded in this budget. The thing to sort of look at and worry about here is that the single largest hospital funding mechanism for safety nets we have in the state is that dark blue, what's called directed payment template or state directed payment funding. That is funding where basically the state tells Medicaid MCOs to pay a much higher rate to safety net hospitals than to other hospitals. It's a way to target Medicaid spending to the providers that need it most. That mechanism was really cut back dramatically in HR 1, although the cuts have not started yet. They're set to begin in January of 2028. But starting in January of 2028, we'll see 10% annual cuts to that funding for the next several years. And so, that's going to really, really squeeze those providers. Health and hospitals in particular here in New York City depends massively on DPT. And so that's a really long-term worry. Um, I'm realizing I'm almost at the time I set for myself and am not nearly done talking. So I'm going to move really quickly. There are a number of sort of perennial questions in the state budget, like scope of practice reforms. Healthcare employers always want lower wage, less credentialed workers to be able to do more. Healthcare unions usually oppose this. And so every year the executive proposes and the legislature rejects some of these scope of practice reforms. That happened again this year. I'm going to skip this one. I want to flag there's an autism treatment that's been in the news recently called applied behavioral analysis that it's one of these Medicaid programs that has grown really dramatically nationwide over the past 5 years, and there's a lot of private equity in it. And it raises, it's basically a good thing. It provides important services for mostly children who suffer from autism. But a lot of the providers in the space are unscrupulous, and it's been a source of major scandals in Minnesota and North Carolina. And so this has been a perennial fight between the legislature and the executive. Every year, the executive proposes sort of setting some guardrails on who can provide this therapy. Every year, the legislature rejects it. That happened again this year. This is a space to watch as we face growing federal scrutiny and nonsense about this stuff. Is that just, we do have a program that has compliance risks. The executive has proposed reforms, the legislature has rejected them, and there is a concern that we could see federal attention to that program. A new question this year, it was independent dispute resolution reform. So this was a new idea in the executive budget. The basic story here is that, the state early and then the federal government more recently passed No Surprises Acts, which basically sort of address what happens when a patient, through no fault of their own, ends up getting a service from an out-of-network healthcare provider, hospital or doctor, usually doctor. And, historically, if this happened to a patient, they could be balance billed for a lot of money. So they could the insurance company would pay a low amount, the provider would want a high amount. And instead of working it out between themselves, the provider would just send the bill to the patient. That was really bad. And so New York, I think in 2014, and the federal government more recently passed laws to address what happens in these situations to basically prevent patients from getting balance billed. And what you need to do there is you need to have a process for deciding what the provider actually gets paid and making the insurer pay that. And so this is a really good idea. The problem at both the state and the federal level is that the sort of arbitration process, the independent dispute resolution process, is really provider friendly. And so the result is that, in these situations, providers can get paid a lot more even than they would get paid if they were in network, if they go through this process. And this creates it increases healthcare spending overall. It creates a bad incentive for providers to stay out of network and exploit the process. The executive proposed big reforms to this, including carving Medicaid out of IDR. The idea there being like Medicaid always pays low rates. It shouldn't be forced by IDR to pay higher rates. And then creating more reasonable arbitration guidance to land on a more sensible price in these processes. The legislature pushed back on that. Of course, it's bad for providers, good for insurers, good for holding down Medicaid spending, but potentially bad for providers. And the enacted reflects a compromise where basically we are carving Medicaid out, so we'll see some Medicaid savings. We are doing a more reasonable arbitration process for NISHIP, for the state public employee plan, but we're not regulating it more broadly for the rest of the insurance market. And there are some loopholes here, so it's not clear how well this is going to work. There were some significant wins from advocates. So school-based health centers are finally permanently carved out of managed care, which is really, really good. They provide an important service. Gambling addiction will now have to be covered by state-regulated insurance. There are some prior authorization limits. So, you won't have to keep getting prior authorization for chronic conditions. But mostly this was a pretty rough budget for healthcare advocates. There was no action on the Essential Plan. There was no action on the Fair Pricing Act, which is a program to prevent some abusive hospital billing practices. There was no action on gender-affirming care. There's still a bill in the state legislature that might do that. And then there was no action on drug pricing. And so looking forward, and I promise I'll wrap up in like 2 minutes, we're facing this really, really dramatic loss of health insurance. We're facing significant federal risks, including, this wasn't really part of the budget process, but the federal government, Dr. Oz and so forth, have been going around to states and sort of accusing their home care programs of being full of fraud. And actually, in the case of Minnesota and California, they've actually tried to claw back Medicaid funding, federal Medicaid funding, using these largely spurious accusations of fraud. And then we're seeing a massive loss of insurance and other sources of funding for safety net hospitals. And finally, and this is something I'll be covering more in the next couple of months, New York's 1115 waiver, a federal waiver that funds a bunch of innovative Medicaid healthcare stuff in New York, is due to expire in less than a year. And a lot of this stuff we're funding is not stuff the Trump administration is going to be sympathetic to. HR 1 also changed how 1115 funding is calculated in a way that might harm New York. And so there are big unknowns there. And then, the big fiscal picture here is, we are not cutting Medicaid spending, but we are cutting Medicaid enrollment by a large amount. There's a little bit of a shift from our funding priorities. Historically, in the past decade, Medicaid spending growth has been driven by long-term care growth to some extent. Now we've seen a pause, at least in long-term care growth, and we're likely to see, and we're seeing increasingly policymakers not take that savings and do a tax cut, but take that savings and increase provider funding. And so provide increasingly hospital rates and nursing home rates are where our Medicaid is going. And we're likely to see further pressure on provider spending as federal cuts phase in. The state may have to intervene to prevent hospital closures. And so we're in a bleak place. And I just want to sort of say, big picture on key issues, we're in a broken policy framework. And so, on home care, Governors Cuomo and Hochul have been trying for years to stop the growth of home care spending. They've been swimming against a tide, I would say, both of aging population and maybe even more importantly, managed long-term care as a system for providing home care has really inflationary and wasteful dynamics. And so, it tends to both grow the program overall while suppressing services for high needs individuals. And, we haven't been doing MLTC for that long in the state. The legacy, of the past decade of MLTC has been wasteful, scandal-filled, and catastrophic. And it's time to really rethink as our population ages, as demand for services grows, how we're doing MLTC or long-term care policy. On hospitals, the perennial issue in state budgets is safety net hospitals that are always on the verge of closure because they get paid inequitably, right? They get paid low Medicaid rates while other hospitals, their competitors, are getting paid high commercial insurance rates. And, basically within that narrow focus, there is this sort of spectrum between you can be a progressive, meaning you just want to pay them more Medicaid money, or you can be a centrist, which means you say, well, do we need these hospitals? Let's hold down spending and let some of these hospitals close. This narrow framework where we just look at the safety nets as the problem really isn't adequate to think about New York State's hospital system. We have to zoom out and say our problem as a state is not that we're spending too little on hospitals and so hospitals keep closing. It's actually that we're misallocating the spending. The private insurance really, really overpays for hospital services, and that drives a lot of private insurance premium growth. And the result is, and whereas Medicaid underpays for Medicaid clients, and that drives hospital closure and loss of service access. And so looking at that funding stream comprehensively and thinking about how to, primarily through price regulation or through global budgets, better target it is sort of the only solution. And absent that, we're going to wind up having sort of Medicaid payments constantly trying to keep up with private insurance payments and never quite catching up. And we're going to continue to have a segregated and unequal provider system. And then on coverage especially, and I really want to emphasize this, we're in a policy framework where policymakers, the governor, the state legislature really, think in terms of employer-sponsored insurance as the gold standard where people should get insurance. And then our social insurance programs, Medicaid and the Essential Plan, as really like a safety net, as something to be, worried about and managed, and sort of why are there so many people on these programs. But the fact is that employer-sponsored insurance in New York State and nationally is really reaching some hard limits on its sustainability. Policymakers have not acted to rein in spending and costs in employer-sponsored insurance. The result is costs go up every year, and insurance gets worse every year. People's deductibles get worse, their premium payments get worse, they get fewer and fewer, higher and higher cost for fewer and fewer services. And so we need to stop looking to employer-sponsored insurance as the solution, especially for low-income New Yorkers, and start to say, No, these innovative and really expensive social insurance programs, Medicaid and the Essential Plan, they provide better insurance at lower costs than employer-sponsored insurance, and it's time to sort of look more to that. At the limit, right, to universal government insurance through the New York Health Act, but in the short term, to expanding rather than cutting programs like the Essential Plan. And so without those shifts in policy framework, I think we're going to continue to see an increasingly bleak healthcare picture in New York. And I'm sorry, I talked for much longer than I thought I would. And so what I'd like to do is just offer to stay on until 1:10 to answer questions if people want to stick around. And I see there are some questions in the chat, so I'm going to run through them. Um, so Elizabeth McCormick asks a really great question about changes to retroactive eligibility in the Article 7 bills. Elizabeth, I'm making a note to get back to you on that. I have not fully parsed that. And so I'll have to get back to you. Michael Burgess asks, have hospitals or FPI estimated losses to health providers, especially in rural New York? We have not done new estimates since the enacted budget, which is likely to move things around a little bit. We were estimating really large on the scale of $10 billion a year losses as of HR1 if the state didn't respond. And, some of those cuts were via the mechanism of insurance losses. Some of them were via the mechanism of DPT. And we haven't updated those since then, but it's something to think about. Rural providers are in a really tough spot. Fundamentally, it's hard to operate a rural hospital at a profit given the sort of scale and volume you have. The rural communities are often really high Medicare, which pays less than commercial insurance. The federal government, as part of HR1, did enact a rural hospital transformation fund to try to keep hospitals open, given the healthcare cuts they had enacted, but it's risibly tiny relative to the scale of need. And so I think rural providers, the state really needs to step up into accepting we're going to have to, if we want hospitals in communities, we have to pay for that. Frankie asks, is there evidence that increased provider rates lead to an increased provider network in Medicaid? The I think the evidence for that is actually better in among physicians than among hospitals. Most hospitals are enrolled Medicaid providers, even if they don't see a lot of Medicaid patients. Unfortunately, physicians, how do I want to say this? The physician lobby in Albany is not as powerful as the hospital lobby, and also most physicians don't have a huge stake in Medicaid rates because they don't treat them very much. And so Medicaid rates for physicians remain really low. I think it would be a smart investment to increase those rates. That was proposed in at least one of the one houses, but has not been enacted. And so instead we saw FQHC rate increases, which is really good. But FQHCs are sort of provide physician services primarily to Medicaid and uninsured populations. There isn't a lot of movement toward mainstreaming those populations. Mm, Bobby asks, how did home care provider rates and consumer coverage do? They did not receive rate increases. There was a proposal in the executive budget to change fee for service LICSA administration costs. I think that did not make it into the enacted budget, but I'll need to check. There's Bobby also asks, what's the impact on Medicaid funding of the CDPAP transition? And that I would say the CDPAP transition caused, because it was so disruptive and made it hard to access care, caused a decline in or a flattening in the curve of the number of people accessing home care in New York, which should save the state money, all else equal. On the other hand, the CDPAP transition also shifted a huge number of people. The state has 80,000 consumers out of roughly 450,000 home care consumers overall. So a huge number of people from CDPAP into agency care, and agency care is more expensive. And so in the medium term, that is actually likely to cost the state some more money. It's unclear whether those two things will balance out. And that's something we'll definitely be looking for in the enacted budget and in future data releases from the state. So the immediate impact was significant savings because of an enrollment decline. The long-term impact is less clear. Carolyn asks, what programs that are currently funded under the 1115 waiver might be at risk? So I would definitely worry about the HERO and other social determinants of health sort of targeted funding streams. The Trump administration has made it clear that it does not believe in social determinants of health and doesn't want to fund them. The Downstate Global Hospital Budget Initiative, which sort of generates some safety net funding for hospitals, mostly in New York City and Westchester, I think is somewhat safer because it's part of the AHEAD model, which the federal government has chosen to continue. I think there's a wonky issue that I'll probably be writing about around 1115 budget neutrality. So basically, a Medicaid waiver is a way for the state to innovate in Medicaid, to say we're going to run our Medicaid program a little differently from what the basic vanilla federal guidelines should suggest. And to get an 1115 waiver, states have to show that they're not going to cost the federal government more than the federal government would pay absent the waiver, that's known as budget neutrality. HR 1 sort of tightened the screws on how you can calculate budget neutrality in a way that's likely to lead to a net loss of funding for the state, whatever specific items sort of come up. It also, the state under the 1115 waiver used a mechanism called Designated State Health Programs, DSHP, not to be confused with DISH, to get federal matching for our VAPAP safety net funding program. I think that's unlikely to continue to be federally matched, which might put the squeeze on whether it continues. So there's a lot to worry about. Felicia asks, the new MCO tax is expected to raise 165 million. What will the state do with this funding? Great question. No one knows. This may become clearer when the enacted budget financial plan comes out in 4 weeks, but right now what we know is that there's a tax and we know the revenue estimate, but we don't know where the money is going. Honestly, it seems like a pretty politically controversial thing to do for what is frankly not that much money. So it's a little bit mysterious where it came from. I would just say broadly that it's really, I'm not one of these guys who likes to complain about Albany transparency stuff. very much, but it is really striking the degree to which the legislature has now passed a budget that, spends a huge amount of money on Medicaid as it does every year, but without that enacted budget financial plan, without any kind of fiscal estimate from officially published by the state, neither we as advocates nor frankly the legislature, as far as I know, really knows how it all nets out, how much money we're talking about, where it's all going. And so, it's a strange situation. Caitlin asks, do you have any knowledge regarding how the state plans to spend the $212 million they received from the Rural Health Transformation Fund program? So this is the federal SOP to rural hospitals that was passed alongside HR 1 to try to mitigate the damage to rural hospitals done by HR 1. The state did release some kind of spending plan. This isn't, anytime you see transformation, the word transformation, that this isn't the ongoing operating support that rural providers are going to need to deal with Medicaid cuts, right? So if 800,000 people lose Medicaid and never get it back, then that creates a consistent year after year red ink in hospitals' budget. And so what you need is consistent year after year operating support. The Rural Health Transformation Program is one-time money. They're going to try to spend it to position providers in a better place to deal with cuts. And that might mean revising service lines. It might mean investing in medical, electronic health records, stuff like that. But you don't undo sort of a permanent cut to operating funding with one-time grants on capital. So that's what I'd say to that. Alessandro Troncoso asks the excellent question, how will Child Health Plus be affected by the federal cuts? So Child Health Plus is a Medicaid-like federally matched program that provides health insurance for children and insures, I think, about 500,000 people in the state. It wasn't directly cut by HR 1. There remain a couple of concerns. One of them is, national studies have shown, and I haven't looked too hard at the New York numbers just yet, but national studies have shown that child Medicaid and CHIP enrollment is down nationally, in part because the federal government has been talking a big game about how their immigration enforcement will remove people. That creates a culture of fear around enrolling for immigrant parents, maybe of citizen children, right? Like they might be worried about accessing it. The other thing is, people often enroll in Medicaid as families, and if you, as an adult, lose your Medicaid due to a work requirement, you might either be confused or there might be additional administrative burden to keeping your children on the program. And so there is a real concern about how these cuts filter down to Child Health Plus, even though it's not directly impacted. Um, uh, Carlos asks, so one of the many ways that this budget sort of provided a little more money to New York City to close its budget gap, but was by restoring Article 6 funding, which is funding, it's a sort of matching funding that the state provides to localities to do public health investment, public health work. And New York City's allocation was cut under Cuomo for vengeful Cuomo-related reasons and has now finally been restored. And Carlos is asking, how can we sort of know in advance how much money we're talking about there? Like, shouldn't that pot of money expand to meet public health needs, which are likely to grow for many reasons in New York City? But that is how the budgeting works. It is sort of fixed in advance, although it's a good point. Um, mm, Ranji asks, do you get the sense that Medicaid will reverse shift back from fee for performance models to fee for service? I would, so New York State, the vast majority of New York State Medicaid spending happens under a managed care paradigm, both in the sort of mainstream health insurance space and also um, in the long-term care space. It within that paradigm, instead of the state directly paying for services, a fee-for-service system, the state pays insurance companies a monthly premium, and the insurance companies pay for services. This is often sold as like a way to do fee for performance or to get value-based payment to incentivize providers to provide high quality care. Um, I will just say largely largely that's all a floor show and sort of especially within the long-term care system, the insurance companies are just sort of pass-throughs for basically fee-for-service fee-for-service structured payments to providers. And I think there have been the Home Care Savings and Reinvestment Act, which has sort of proposed shifting us away from managed care, at least in the long-term care space, as Connecticut has done to good effect, would eliminate that system. And I think that would be incredibly, incredibly positive, particularly in long-term care, where, as I said during my talk, I think managed long-term care has really been a policy failure in New York. And I think I don't see any other questions, and also my voice is giving out. So thank you all so much for coming. Sorry for going a little bit over. Kieran mentions that I'm going to try a new thing this summer. Starting in July, I will be teaching a 4-session Medicaid Summer School. So if you ever want like more than the briefing, the full story of like how Medicaid works in New York, what managed care is, what the heck an 1115 waiver is, how we got to where we are with our home care program, stuff like that. It's going to be in the evenings on Wednesdays, starting July 15th for 4 sessions, and it's aimed at both a general audience and a wonky audience, right? So I hope it will be accessible to sort of grassroots activists, and also that folks at unions and advocacy organizations who know a little more will really benefit from it. So I would love to see all or some of you there, and thank you again for coming to the briefing.